L&D complications are all about what happens when mom doesn't follow the natural, normal time course. That is, something happens that's supposed to happen, but just doesn't happen at the right time. Let's start with rupture of membranes and then use that to build on abnormalities of ruptures of membranes before we move into preterm labor and post-dates. So rupture of membranes is something that is supposed to happen. Baby is contained in a sac, and in order to come out of mom, that sac has to rupture. Baby can be delivered in the sac, but the normal process is that that sac ruptures and baby comes out. So as the sac ruptures, a bunch of fluid comes out. Now this can happen spontaneously, and it's supposed to happen about within 1 hour from delivery onset. Now again, a baby can come out in the sac, but generally you want that membrane ruptured. So it can also be occurred artificially. That is, we do it. We purposely go in and rupture that sac. Or if it happens too soon, it can be a result of an infection, and so it can be pathologic. But the normal rupture of membranes is spontaneous and occurs within 1 hour of delivery onset. And what mom will experience is a rush of fluid. It may have blood in it. And it's not just a little spotting, it's a rush of fluid that's going to soak the gown, her clothes, or the bed. Now, if it's a first-time mom, the sight of a rush of fluid that's bloody is going to prompt her to come in and see you right away. If it's a multiparous woman who knows what this means, she's going to come in and see you. And the first thing you're going to do, of course, is make sure that this actually was a rupture of membranes. And the first thing to do to determine that is a speculum exam. And the speculum exam will show you pooling of fluid in the vagina. And then you're going to do the nitralazine blue test. Application of nitralazine to that fluid turns it blue. Or you can look at it under a microscope and see the Fern sign. And then, this is not necessary, but you can confirm that it actually was all the amniotic fluid that came out of the sac with an ultrasound. If you see oligohydramnios after rupture of membranes, that is anticipated and expected. Right? They had the right amount of fluid in when the sac was intact, sac ruptures, all of that fluid comes out, oligohydramnios thereafter, no more fluid in the sac. The treatment, if it was normal rupture of membranes, is just expectant delivery, expectant management. You essentially just continue delivery. So this is supposed to happen. This is normal rupturing of membranes. What happens if it is premature rupture of membranes? And premature means baby is ready, mom is not. It is caused by an ascending infection. And you're going to have to get this differentiated from preterm rupture of membranes, PPROM. Premature rupture of membranes is baby is ready. The gestational age is at term. Baby's ready to come out. There just aren't any contractions. So mom's not ready. Baby's ready, mom's not. Premature rupture of membranes. All you're going to do is diagnose that rupture of membranes has actually happened, which is the same as ROM. You're going to do a speculum exam and see the pooling of fluid, which responds to nitralazine by turning blue, and you're going to see the Fern sign, and then oligohydramnios. The thing that's different is that this ascending infection led to premature rupture of membranes. It wasn't delivery. So because it's an infection, you're going to treat with antibiotics. Because it's caused by, most commonly, E. coli, you're going to treat with AMP and GEN. You cannot give fluoroquinolones because she's pregnant. This was premature rupture of membranes. Baby's ready, mom's not, caused by infection. If you have preterm rupture of membranes, it is by definition also premature. So it's written P-prom. The path is still an ascending infection, most commonly with E. coli. Only now, the difference being baby's not at term. So baby's not ready and mom's not ready, but there was still rupture of membranes. The diagnosis of rupture of membranes is made the same way as for rupture of membranes. You're going to see pooling in the back of the vagina. You're going to get an hydralazine test, which is going to turn it blue. You're going to see the Fern sign and oligohydramnios on ultrasound. But now the treatment isn't just treat the infection and deliver. The problem is now you have to figure out, is baby ready to come out? Now, if it was greater than 36 weeks, well, that's technically premature rupture of membranes, deliver with antibiotics. If it's less than 24 weeks, that's not going to be viable. You deliver, but it's actually called an abortion. But if it's in between, baby will benefit from being inside mom longer, even though there's an increased risk of that infection getting to baby. So if they're in between 24 and 36 weeks and they have a preterm premature rupture of membranes, you want to keep baby inside mom and give baby steroids. Steroids are going to increase lung development. Now you give them to mom unless mom gives them to baby. Of course, you're also going to treat with antibiotics, Ampigen. For both of these conditions, you never do a digital exam. The reason being, even if you're wearing sterile gloves, you're going to introduce the vaginal flora into the uterus, and you can cause a serious infection that we'll talk about in just 1 second. So that is premature rupture of membranes, baby ready, mom not, and preterm rupture of membranes, neither baby nor mom is ready, and because it is preterm, it is inherently premature. What happens now if ROM happens or one of these conditions happens and it's too long from the onset of ROM to delivery? Prolonged ROM is defined as greater than 18 hours from ROM onset to delivery. It can be a totally normal delivery that just takes too long, maybe because mom's brand new at this. So if ruptures of membranes occurs and there's 18 hours from ROM to delivery, there is an increased risk of group B strep infection. So the patient is going to be just that. It's going to be someone who has had ROM, regardless of whether it's preterm, premature, or normal, but it takes longer from that ROM to delivery than 18 hours. The diagnosis, all you need to do is confirm that ROM had happened, and so you're going to do the same thing that you did before, nitrilazine, Fern test, and oligohydramnios. But now you need to treat as if baby's been infected with group B strep. You're going to prophylax with amoxicillin. So this is the case where moms goes through a totally normal pregnancy. She just takes too long to get baby out. You want to make sure she's not GBS infected, so you prophylax with amoxicillin. And the reason why you don't want to leave ROM open for too long, and the risk you run of dealing with preterm and premature ROM, is that you can get that ascending infection into the uterus. That is chorioamnionitis and endometritis. This is also caused by an ascending infection. The same ascending infection that caused premature and preterm ROM. The only difference now is that if the infection gets into the amniotic sac, that is, baby is still in, it's chorioamnitis. And it's endometritis if that infection got in when baby is out. It only gets into mom's uterus. The patient is going to present with ROM, generally preterm or premature ROM, and a fever. This isn't just an infection within her vagina. And by the way, the ascending infections before are vaginal organisms. So if you've got a culture of the fluid, you just see normal vaginal organisms. Now, those vaginal organisms have gotten into mom's sterile uterus. She is responding to the infection. So you'll see systemic signs of infection, not just rupture of membranes. The diagnosis is presumed from this presentation, so your job is to rule out other infections. You don't want to assume that mom has endometritis when she could have a pneumonia, a UTI, or meningitis. So you have to look at the clinical vignette, look at the scenario, and decide, is this the most likely source of fever? While you do that, you're going to treat with broad-spectrum antibiotics. Generally, this means piptazo, which is Zosyn. You're covering for essentially all infections, including those that cause vaginal infections and infections that would lead to PROM or PPROM. That's going to conclude our talk about premature rupture of membranes and the infections that can result. Let's move on now to another labor and delivery complication, preterm labor. Preterm labor can occur for a whole variety of reasons. The pathogenesis is essentially unknown, but risk is increased when women are smoking, when mom is very young, generally less than 20 years old, when there's multiple gestations, or there's been premature preterm rupture of membranes, or abnormal uterine anatomy. For whatever reason that she goes into labor, mom is going to begin having contractions, but baby is at a gestational age less than term. And that is the definition. She'll have contractions and she'll have cervical change. That's saying she's going into labor, but baby's not ready. That is essentially the definition. But baby has to be between 20 and 36 weeks. Here's why. If you are between 40 and 36 weeks, you are said to be full term. Any more than that, you're post dates. But less than 20 weeks is considered an abortion. Viability is really only present after 24 weeks. But the delivery between 20 and 36 is considered preterm. And if you are born at 24 weeks, you have a very tumultuous course in the NICU developing up to term. But what you have to do is simply diagnose and confirm that she is in labor. It is a clinical diagnosis. And the treatment is going to focus around two things. Keeping baby in mom, that is stopping labor so that baby can develop, and giving baby the assistance it needs to develop its lungs. So you're going to delay delivery, and generally these mechanisms only work to buy you hours to days, not days to weeks. But you can try mag sulfate, beta agonists like terbutaline, calcium channel blockers like nifedipine, and prostaglandins like indomethacin. These are all tocolytics designed to delay contractions, to prevent cervical change, and to let baby stay in longer. While you delay delivery, because you're only going to get a couple of days, you want to develop baby. And the goal is the lungs. Give mom steroids especially if the lecithin to sphingomyelin ratio is less than 2:1. If you get some amniocentesis, get some amniotic fluid, and identify that baby's not ready, give them steroids. Now, there are certain exceptions to delaying labor. That is, the contraindications to delaying labor come in 3 parts. Maternal causes are something like preeclampsia, where delivery of the fetus is the only way to prevent seizures from coming on. If mom's preeclamptic, baby's coming out, doesn't matter where they're at in their gestational age. If there's fetal demise, this is a fetal complication, what's the point of keeping baby in? And finally, there's anatomical reasons, such as rupture of membranes that occurred too soon, or conditions that are going to kill mom, like a placental abruption. Placental reasons, fetal reasons, maternal reasons. Look for contraindications to delay delivery, and if they're not present, delay for as long as possible with tocolytics and develop baby with steroids. So this is what happens when baby comes out too soon. What happens when baby's in too long? That is the final thing we're going to close with, the post-dates fetus. Post-dates is defined by greater than 40 weeks from conception. But conception is a difficult time to narrow down. So if you have a reasonably good idea of when those dates were by an ultrasound in the first trimester, you can kind of use that. Or we define it by greater than 42 weeks from the last known menstrual period, the last normal menstrual period. And the problem with post-dates babies is that they're going to be big, which puts them at risk for shoulder dystocia, and they're going to be dysmature. You're going to learn more about the dysmature neonate in pediatrics. But just know that overdevelopment is not good. Underdevelopment is not good either. Babies need to be delivered at term. To diagnose a baby post-dates, you simply look at how long baby's been in. And the treatment is going to depend on how sure you are and how ready mom is. So it's dependent on the dates, on cervical favorableness, that determines the treatment. If you are sure of the dates, that is, you got that first trimester ultrasound, or she was doing family planning, you know that she is for sure post-dates. If mom has a cervix that is favorable, that is, she's ready to deliver, you can induce with Pitocin. But if you're sure that baby is post-dates and mom is not ready, then you go to C-section. The question on your test is going to be, we think, but we're not sure the baby's post-dates. And so it doesn't matter what mom is, you are going to use the biophysical profile. That is, you're going to get a non-stress test and an amniotic fluid index with ultrasound. And you're going to decide, how is baby doing? Remember, if you find a woman in the 3rd trimester, that's when you diagnosed her pregnancy, the ultrasound is not going to give you reliable dates, as the variability is plus minus 3 weeks. So that's the difference between someone who is going to be preterm versus someone who's going to be post-dates. So what you want to do is not just use the ultrasound to find out how old they are, but find out how well baby is doing. If baby's doing good and you're not sure it's post-dates or not, let it cook longer. If there's any sign of distress, well then you need to go to delivery either through induction or C-section. Okay, so in this lecture we talked about a lot of the different pathologies that can occur in labor and delivery. Labor and delivery is supposed to take a normal time course. But if baby comes out too soon, preterm labor, you need to recognize how to keep baby in to let it cook a little longer. If baby stays in too long, that's not good either. You need to know when baby needs to come out. And then you need to understand the pathology of rupture of membranes. The idea is that abnormal timing is caused by an ascending infection. You have to treat the infection before it gets into mom's uterus, causing endometritis. And also that prolonged rupture of membrane, even though it may have been a normal delivery up to that point, puts baby at risk for group B strep, and you need to prophylax against it. That is L&D complications. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.